I think I'm going to give you just a general introduction to, again, what the waiver is and what the particular opportunities are, and then Michelle will talk about some of the specific care coordination components. So, to begin, there we go. To begin, I like to start with this kind of pyramid slide, as we call it, and it gives us a little bit of a review of what's happened recently in health policy with respect to the Affordable Care Act, as it's called affectionately, or not, Obamacare, as it's called affectionately, or not, as we have heard, particularly last night, with some viewing that we had last night available to us. But in any case, it's been a big change for us in the safety net and in the Medi-Cal program. And so, as we know, the bill passed, the Affordable Care Act, in 2010. In 2014, there was a big expansion. Over 4 million people came newly into the Medi-Cal program. So a huge win for those who were previously uninsured and were not eligible for Medi-Cal because they didn't have the right set of characteristics, for example. Whereas now there's a national floor in the states that are in the coalition of the willing that implemented the Medi-Cal expansion under 138% of poverty. If you are a citizen or a legal permanent resident, or in California, if you're a child, regardless of your documentation status, up to actually 250% of poverty in California, if you're a child, you're eligible for Medicaid. And so that was a huge win, fully and aggressively implemented here in California. And one interesting thing the state did along with expanding the Medi-Cal program was also to add some new substance use disorder benefits. So this is a little bit of the story of how all of this happened, and I'll just tell it quickly, but basically the state said we want to add some new benefits. With voluntary withdrawal management, residential treatment, which Wes mentioned earlier in his sort of opening and talking about how benefits have expanded, in addition to intensive outpatient treatment, and expanding that from just narrower benefits that apply to certain groups of people to everybody in the drug Medi-Cal program. The federal government, they were okay with the intensive outpatient benefit. They were okay with the inpatient withdrawal management benefit addition. What they were not so hot on was the residential benefit. And again, Wes referred to the IMD exclusion, or Institution for Mental Disease exclusion, which basically says if you have more than 16 beds in a facility, you can't bill for Medicaid for substance use disorder treatment services. And so the state, in its wisdom, said, okay, federal government, I see you, I hear you. So let's do this through an 1115 waiver. And lo and behold, after extensive negotiation, as you can see in the timeline there, in the pyramid graphic up there, the federal government eventually said, yes, okay, we'll allow you to do this. And basically what happened is, at the very end of the previous 1115 Medicaid waiver, and for those of you who aren't familiar with waiver speak, that's basically the opportunity the federal government gives to the states to say, hey, if you want to do something new and improved in your Medi-Cal program to improve outcomes, to expand eligibility, save money, that sort of thing, advance the delivery systems, you can do that through this opportunity. It's a section of the Social Security Act for those of you who are, federal statute and regulation buffs like me. You can impress your friends with that really extensive knowledge of the Social Security Act. So, in any case, that was approved, but basically near the end of the previous waiver. And so the state then elected to roll it into this present waiver, which began at the beginning of this calendar year and rolls all the way through 2020. So we have about 4 years left in this waiver to really get this up and running. We're doing it as quickly as possible. Our target for launch is July 1st, 2017 for the DMC-ODS here in LA County. And we then have about 3.5 years of solid time to really get some experience and demonstrate what we can do with this expanded benefits package. The last thing I want to note before I move on from this slide is that as of July 1st, 2016 of this calendar year, so this is already happening, we have added a substance use disorder benefit to the My Health LA program, which is for people who are undocumented in LA County, who are, for that reason, not eligible for Medi-Cal. So we're creating a mirror benefit for people who are not eligible for Medi-Cal, which will essentially be the same as what's available through drug Medi-Cal or through the DMC-ODS waiver. So I think I already talked about this, basically just introducing what a Section 1115 waiver is. And as I said, it's to expand coverage, strengthen delivery systems, strengthen health outcomes, that sort of thing, improve quality of care. And so this is just a little background about what exists. All states have them, and we're fortunate enough that California chose to include the DMC ODS as a major plank of its 1115 waiver. So we should again take full advantage of it in the coming 4 years. So this is just a little tour through what's in the Medi-Cal 2020 waiver. So as I mentioned, DMC ODS is a major part of this, but there are all kinds of pieces of this, and some of them were mentioned in the presentations this morning. So whole person care, there's a dental care, part of the Medi-Cal program overhaul that's going on through the waiver. Prime, which also LA County is very involved in redesigning our public hospital programs and the incentives associated with it. The Global Payment Program also is a very important program for caring for the undocumented and uninsured, and merged the different financing streams for caring for those groups through the different financing streams we have for the uninsured in California. And these are some of the continued waiver components. So these were in the previous waiver or previous waivers, and have been continued again through this Medi-Cal waiver. And of course, in the bottom is really the DMC ODS, which is the focus of our presentation today, and we'll talk about some more of the specifics of that. So what's in this thing? Why is this important? First of all, as I said before, this all began with the desire to expand benefits. Benefits have been historically very limited. They were limited to who you were, if you were a child, or, for example, a pregnant woman, perinatal benefits. Not everybody in the Medi-Cal program was eligible for all of the benefits that were available through Drug Medi-Cal. There are also clinical reforms that are associated with it. So the ASAM criteria, as we call them, or the criteria of the American Society for Addiction Medicine, are a big piece of this and must be applied to determine what level of care or medical necessity exists within the Drug Medi-Cal program. So there's a clinical overhaul in terms of deciding what's appropriate. And some standardization there across the different providers and programs. In addition, there are new evidence-based practices that are required. So this is another important clinical component. Here in LA County, the two that we've selected to include in our program that we're implementing are motivational interviewing and cognitive behavioral therapy. In addition, and this is a new addition to our delivery system, is quality improvement and utilization management. So these are managed care components that, again, have not been really a part of the Drug Medi-Cal program, and certainly not a part of the program here in LA County. And one requirement that's included in that, that's very, I think, prominently focused on in the terms and conditions that the state wrote and had approved by the federal government, is pre-authorization for residential treatment. That is a required part of approving care for that group of people who need or have medical necessity for that level of treatment. In addition, there's more administrative oversight and accountability transferred to counties. So the state sends realignment funds to counties to operate the programs, and they've also said, since we have given you this opportunity to do something bigger and more expanded, you also will be seen now as a selective contractor. So counties will have responsibility for overseeing the quality and oversight fully of their providers, and can basically say, this is our network, it is a closed network of providers. We will select providers based on their performance and quality. And presently, that's not fully within our control. So the state can directly contract with providers in our county and use the financing that has been given to us to pay for those services outside of our own contracts. That practice will end once we implement the DMC ODS waiver, again, as a selective contracting entity. This is a really important one too, the next bullet. We will have better rates. I'll say it again, we will have better rates. So right now, as many of you know, if you're a contracted provider or somebody in the treatment community, you know that the rates in DMC are not good, and that's putting it politely. They're not very competitive, they're not covering the cost of what you do in many cases, and we are working very hard right now with DHCS, with the state, to fix that. We are proposing a set of new rates that will cover the cost of care that you provide, and also should allow you to make new important investments in the things that we talked about. Having the clinical staff that you need, who are trained in ASAM, who are trained in motivational interviewing and cognitive behavioral therapy, who can make new business investments and do quality improvement projects, that sort of thing. Who can hire licensed practitioners to do determinations of medical necessity, all things that will be required. And as we said before, a big priority of this waiver, there are three major components, I think, to it, or major aims of it. Number one, as I said earlier, to expand care, expand benefits. So that's number one. I think number 2 is to organize. It is an organized delivery system, which is a word included in the title of it, so that we're having new kind of managed care practices, new standards clinically, that sort of thing, but in addition to integrate care. So there are many components of this that really advance the integration of care, and we'll talk about many of them, and really peppered throughout this presentation, we'll focus on how this new opportunity allows us to coordinate care more meaningfully for many different vulnerable groups that we serve, including the homeless, which we talked about this morning. I always like to pause at this slide. So this is my Joe Biden slide. I'll put my tongue in my cheek now. So this is a big deal. And of course, I cleaned that up a little bit. But we always have to stop and just emphasize that everybody knows this is a generational opportunity to really transform SUD treatment for the safety net and more generally, so that we can demonstrate what we can do with a meaningful, comprehensive benefits package and an advanced delivery system for this type of care and for this chronic disease. It is a watershed moment for the Medi-Cal program. It's a watershed moment for our program here in Los Angeles County, for the Health Agency, and for the Department of Public Health. And it's a watershed moment for SUD treatment. And we really here in LA County in our program want to leverage it to reframe SUD as a chronic disease and to create a delivery system and a treatment system that treats it as such. It is not a moral failing. It is not criminal behavior. It is a chronic disease. And so we're transforming the delivery system to treat that way and to connect people with this chronic disease to all of the services that they need. So, with that, I'm going to turn it over to Michelle to talk more about the specific pieces of it and what we're up to right now at SAPC. So, Michelle.